Do government agencies push statins? Well, today we're going to look at a case study of exactly that, the U.S. Medicare system. And while a lot of my viewers are actually not from the U.S., I think you'll find it instructive to see what's being done here so you may be able to determine if it's happening in your country. Stay tuned. Well, since about 40% of my viewers aren't in the U.S., I think I should just take a brief moment to describe what the U.S. Medicare system is. It's a U.S. government-sponsored medical insurance for people 65 and older or disabled, and it's different from Medicaid or the Affordable Care Act, also known as Obamacare, that you may have heard of in the news. American workers pay 1.45% of each paycheck into the Medicare fund, and their employers do a similar match. It's very complex, has multiple parts. Even somebody who's been paying into the system all their lives really needs professional help in navigating it in order to make sure that they get the best insurance coverage. So I'm not able to advise anybody on how to get through that. I actually went through an agent who took care of it for me. So for today's review, I have this paper here. It's the evaluation of a pharmacist-led intervention to improve statin use in persons with diabetes. I'm not criticizing the work that was being done here. They actually achieved the objective that they set out to do, and they were incentivized to do it, so it was really good work in that sense. So the objective was to improve rates of statin prescribing, and by improve, they mean increase, in people with diabetes in a particular medical health plan, and that it was in Denver, Colorado, in the United States. And they had pharmacists who were leading this effort. They did a remarkable job. They achieved exactly what they needed to achieve. What the study adds is a section of this paper that I'm reviewing, and they point out these things. Population level management by pharmacists is effective in ensuring patients with diabetes are receiving appropriate statin therapy. I disagree with the use of the words here, the appropriate statin therapy, but it's certainly appropriate under the rules that they are forced to live under. Pharmacists are well equipped to risk stratify patients and to review their histories for statin intolerances, allergies, and contraindications. That's good that they recognize that statin intolerance exists. Then they say direct statin prescribing by pharmacists is an effective way to ensure that patients with diabetes are receiving, again, that word appropriate, which I don't like here, statin therapy. When they say direct statin prescribing, pharmacists in the United States don't actually get to prescribe, at least not yet. They don't get to prescribe statins. As far as I know, though, that idea has been floated out there, and this was written in 2020. They were still going through a doctor, but they were initiating the prescription by bringing it to the doctor's attention. And here's a key thing. The statin use in persons with diabetes, the SUPD measure, is a star rating quality measure by which health plans are graded, so we need to take a look at that. So what is the 5-star quality rating system? Well, the Center for Medicare and Medicaid Services has this star rating program. I'm just going to read the highlighted points here. They operate a star rating program that measures a plan's performance on selected quality measures. Star ratings are used to measure the quality of the health plan. The ultimate goal is to improve the level of accountability and quality of healthcare in organizations and providers. Those are all great goals. You would think that that would be a good thing. And then here's a sample table, statin use in persons with diabetes measures. Basically, the more people with diabetes that you have on statins, the higher your star rating. Now, if you watch my last video, you'll see why that can be a problem. So this quality rating system has a bunch of health-related ratings, but they also have like service-related ones, like how satisfied are people with the program, how quickly do prescriptions get filled, how quickly do reimbursements come in, that sort of thing. Under the health-related matters, they have a bunch of categories under screening and monitoring, some under medications and under management and control. So under screening and monitoring, these are the sorts of things that you would expect to see. Breast cancer screening, colorectal cancer screening. These are the things that the higher percentage that these things are done, well, the better service they're providing. And under management control, they have similar things. Reducing risk of falling, rheumatoid arthritis management, diabetes care, blood sugar control. Under medications, though, they have several measures. How many people get their annual flu vaccine, medication adherence for people with diabetes. In other words, how many people are filling their diabetes medications and taking them. And they allow for 7 different diabetes medications. That's what the numbers in the parentheses are, the number of different classes of medications that count towards this metric. For hypertension, high blood pressure, there are 3 different classes of medications that a person can take for that. But you notice the 3 in red. There are 3 devoted exclusively to statins and statins only. Statin therapy for patients with cardiovascular disease. Okay, that's secondary prevention. I really don't take positions on secondary prevention. I've been asked from some viewers to review that, so I may start studying that, but that's high-risk patients, and I'd rather not give anybody the impression that I would tell a high-risk patient not to follow their doctor's orders when it comes to medications, even if it's statins, if you can tolerate them. Statin adherence for cholesterol. So in other words, they see cholesterol in and of itself being a bad thing. Nothing else counts, only statins. Bempedoic acid doesn't count, ezetimibe doesn't count, bioacid sequestrants don't count, PCSK9 inhibitors don't count. No, if people have cholesterol that's out of range by their definition, by they I mean Medicare definition, or actually it's standards of care, then they have to take statins. And then there is statin use in patients with diabetes. That's the one that we'll be drilling down in more detail today. So here are the assumptions that they go by when they're rating the statin use of people with diabetes. First, they use the 2018 Multi-Society Cholesterol Guideline, which is basically a distillation of the 2018 Standards of Care that I have reviewed before. They're the same things. There's just a few extra comments by a doctor in there that add clarification. Patients between 40 and 75 with diabetes and LDL between 70 and 189 should be on moderate intensity statin therapy. Well, if you think about that, if you've got an LDL as low as 70, you probably have a total cholesterol of 140 milligrams per deciliter, or 3.6 millimoles per liter, on the lower end of this range. And that's a very low total cholesterol level, given what our bodies need. Now, if your cholesterol level is that low naturally, well, I wouldn't worry about it because your liver understands how much cholesterol you need and is only making that amount. But if you're artificially forcing people down to that level, that's where a lot of adverse effects come in, the adverse consequences of low cholesterol. And then they encourage moderate to high intensity statin for anyone 40 to 75 with diabetes, regardless of what the risk calculator says. Now, the risk calculators account for the presence of diabetes, so they're just saying, throw that out. We're just going to give it to people with diabetes, even though there's really no mathematical justification for doing that. So what were the results of the Denver Health Medical Plan effort to increase statin usage? In 2017, 79% of eligible patients were on statins, and they got a 3-star rating. And then it dropped to 65.7%, and they were down to a 1-star rating. They say, well, we've got a problem here, and we'll find out why they say this would be a problem. Prior to initiating this effort, they were at 1 star. And in the paper, they give population data. It's kind of hard to follow the numbers just because with things like this, it's not as straightforward as you would think. People drop out of the plan, people pass on, people come into the plan. But they had an original pool of just over 1,000 patients. They found that 15.7% of them in the pool were not on statins because they had contraindications, which means maybe a pregnant woman, that's a contraindication. You don't want to put a pregnant woman on statins. Or they had statin intolerance or allergies. So those people with this star measure can be set aside and not included in the total amount. They went over 326 patient cases who were not currently on statins out of this original 1,000 patients. Most of them were on statins. And 64 refused treatment, said, no, I'm not going on statin, so good for them. For 6 patients, doctors refused the statin initiation. They wanted to actually talk to the patient first. And that's why I say that it seems like the pharmacists were not able to actually directly initiate the prescription. They still had to go through a doctor, so that's a good thing. Very few of them balked at it, but hey, that's still good that some doctors said, no, we're not just going to automatically do this. I want to review it myself. They ended up initiating 115 new prescriptions. They ended up with an 87.1% success rate in getting people onto statins. So that was a 5-star rating for them. So there's some controversies here. Here's some quotes from different sources. This is from the paper that I'm reviewing. And they say there's no available report of LDL-C levels achieved after statin initiation. Many of my viewers would say, well, that's not a problem. We don't really care about LDL levels. And I get that. But the point is they're prescribing statins to lower LDL, yet they're not even looking at what the results are. The Pharmacy Quality Alliance measure is classified as a process measure, since prescribing a statin is noted to be a step that should be followed to provide good care, rather than the outcome. Boy, that's a bizarre sentiment there. Process measures such as the statin use by people with diabetes focus on whether the actions have been shown to benefit patients as a whole is what they're claiming there, but they do not require a report on clinical outcomes achieved. Think about that. All they want to do is put people on statins. We don't care what it does. We're not going to look at the results. We're not going to look at how many people are injured by this. We're not going to look at whether it actually achieved what we think it ought to achieve, which is lowering LDL, which I think most of my viewers will agree is not in and of itself necessarily the right thing to do. If you have low quality LDL, perhaps it is, but if you have LDL pattern A, something like that, then maybe it doesn't have to be done. But they're not even measuring it. The only measurement here is you get 5 stars if you get people on statins. To hell with what happens to them afterwards. Next, they go on to say, our project's effect on the Denver Health Medical Plan has potential positive financial implications that will be realized in the future through an improved overall Medicare Plan Star rating. There is a financial incentive to this that they get from Medicare. Achievement of a 5-star rating is associated with increased Medicare payments per member per month, bonus payments, and additional rebates that will allow the plan to provide more value to our members. From what I understand, this is a nonprofit organization, but even nonprofits have to work with a budget, so they are incentivized to get these 5-star ratings, which means put people on statins regardless of the consequences, because the consequences for them is going to be more cash flow into their organization. And we do have to understand that that's something that is going to help them serve the public better, but they're doing this without question and without even reviewing whether it's helping or not. It's not their fault. That's what they're incentivized to do by the Medicare system. There is a online tool that uses the Medicare Star Rating System. If the Medicare gives a plan fewer than 3 stars for 3 years in a row, the plan finder, which is apparently the tool, flags it as low performing. The 5-star rating, they actually add them all up to get a roll up of the total 5-star rating. So the statin part of this is only a small part of it. So an organization, I suppose, could have 1-star ratings in the statin area and still get a 5-star rating if they were really good in all the other areas, both administrative and medical. The point is they are incentivized to get as many of these individual metrics up to the 5 stars possible, and that includes the 3 statin ones. When you think about that, out of all the medical ones, 1 out of 6 has to do with statins. That's just incredible to me. You cannot use this tool to enroll in a low-performing plan. In other words, they make it more difficult for somebody. You know, people are getting online, they want to enroll in their medical plan. They won't get kicked out of a low-performing plan, but if they want to get into one, they have to go through extra steps, which just means that the plan is going to get punished for being low-performing by these metrics. So there is the incentive to push the statins so that they can get a higher rating there, and ultimately it rolls up and they get more business, so to speak. So my conclusion in all this, well, health organizations and insurance plans both are rewarded by Medicare specifically for getting patients onto statins and keeping them on. Because if you look into the details of some of these metrics, they talk about, has the patient filled enough to cover 80% of the year or whatever, and that would indicate to them that they're probably taking the statins, although they may occasionally be missing it. This is independent of the clinical results, and that's the part that just blows my mind. We're just going to push statins on people. We're going to get extra money back for it, and that's our fiduciary duty to the organization. So I hope you found this brief little look interesting. For the 40% of my viewers who are from outside the United States, I'd really appreciate hearing from you. What's happening in your nations? I think UK is a big statin pushing country. I think Australia maybe also. I'm not sure about any others. But if you have experience with this, I'd appreciate hearing about it. If you appreciate this content, please like, share, subscribe, and comment on this topic or others you'd like me to cover. And if you haven't seen this video, I recommend you take a look at it now. Thanks for listening.